During pediatric cardiac arrest, the most reliable indicator of high-quality chest compressions is A. Chest recoil between compressions. B. Audible clicking of the backboard. C. Visible chest movement. D. EtCO2 greater than 15 millimeters of mercury. Answer, D. EtCO2 readings above 15 millimeters of mercury indicate adequate perfusion and effective compressions during resuscitation. A 5-year-old is unresponsive with a pulse of 30 bpm and gasping breaths. The next step is to A. Begin chest compressions. B. Provide rescue breathing only. C. Check for trauma. D. Apply a cervical collar. Answer, A. In children, a heart rate under 60 bpm with poor perfusion requires immediate CPR. The first drug for pediatric pulseless ventricular tachycardia is A. Atropine. B. Adenosine. C. Epinephrine. D. Amiodarone. Answer, C. Epinephrine 0.01 mg per kilogram 4/IO is given every 3 to 5 minutes during pulseless rhythms before antiarrhythmics. The preferred airway adjunct for a semi-conscious child with no gag reflex is A. Oropharyngeal airway. B. Nasopharyngeal airway. C. Bag valve mask. D. Endotracheal tube. Answer, B. A nasopharyngeal airway, B, can be used in a semi-conscious child because it does not trigger the gag reflex, unlike an oropharyngeal airway. In pediatric bradycardia with poor perfusion, the first-line medication after oxygen and compressions is A. Amiodarone. B. Atropine. C. Epinephrine. D. Lidocaine. Answer, C. Epinephrine improves heart rate and perfusion by stimulating cardiac output. A shock dose for pediatric defibrillation, first shock, is A. 1J/kg. B. 2J/kg. C. 3J/kg. D. 4J/kg. Answer, B. The initial shock for VF/pulseless VT is 2J/kg, subsequent shocks increase to 4J/kg. During CPR, interruptions should not exceed A. 10 seconds. B. 15 seconds. C. 20 seconds. D. 5 seconds. Answer, A. Minimizing interruptions ensures continuous perfusion pressure for effective resuscitation. A 2-year-old with severe respiratory distress, retractions, and wheezing unrelieved by bronchodilators should receive A. Epinephrine nebulized. B. Magnesium sulfate 4. C. Dextrose 4. D. Adenosine. Answer, B. For magnesium is effective in severe, refractory asthma during respiratory failure. Which rhythm requires immediate defibrillation? A. Asystole. B. P. C. VF. D. Sinus bradycardia. Answer, C. Ventricular fibrillation and pulseless VT are shockable cardiac arrest rhythms. The most accurate method to confirm endotracheal tube placement is A. Waveform capnography. B. Condensation in the tube. C. Chest rise. D. Equal breath sounds. Answer, A. Continuous waveform capnography confirms effective ventilation and correct tube placement. During pediatric cardiac arrest, when using an AED, if pads overlap, you should A. Use smaller pads. B. Remove one pad. C. Place pads anterior-posterior. D. Continue with overlap. Answer, C. Anterior-posterior pad placement prevents overlap and ensures effective shock delivery. The compression-to-ventilation ratio for 2 rescuers in infants or children is A. 15:2, B. 30:2, C. 10:1, D. 5:1. Answer A. 2 rescuers perform 15 compressions followed by 2 breaths in pediatric patients. Epinephrine 4 dose for pediatric cardiac arrest is A. 0.1 mg per kilogram, B. 0.01 mg per kilogram, C. 1 mg per kilogram, D. 0.1 milliliters per kilogram of 1:1000. Answer B. Use 0.01 mg per kilogram of 1 to 10,000 concentration 4/IO every 3 to 5 minutes during arrest. The golden minute in neonatal and pediatric resuscitation refers to A. First minute of CPR, B. Time to establish ventilation, C. First defibrillation, D. Time to first epinephrine. Answer B. Effective ventilation should be achieved within 60 seconds of recognizing distress. Which drug should be avoided in wide complex tachycardia of uncertain origin? A. Adenosine, B. Amiodarone, C. Epinephrine, D. Lidocaine. Answer A. Adenosine may cause asystole in irregular or polymorphic VT, avoid unless clearly SVT. The main cause of pediatric cardiac arrest is A. Primary arrhythmia, B. Trauma, C. Respiratory failure or shock, D. Myocardial infarction. Answer C. Most pediatric arrests begin with respiratory or circulatory compromise, not primary cardiac causes. In septic shock unresponsive to fluids, the preferred first vasoactive drug is A. Epinephrine, B. Dopamine, C. Norepinephrine, D. Phenylephrine. Answer A. Epinephrine supports both contractility and perfusion in fluid-refractory septic shock. In post-cardiac arrest care, maintaining normothermia means keeping core temperature A. Below 32 degrees Celsius, B. 36 to 37.5 degrees Celsius, C. Above 39 degrees Celsius, D. At 34 degrees Celsius constant. Answer B. Avoiding fever and hypothermia optimizes recovery and neurological outcomes. The priority assessment in the initial PALS survey is A. Circulation, B. Airway, C. Disability, D. Breathing. Answer B. Airway assessment and management are the first step in PALS's systematic ABCD approach. The recommended ventilation rate for a child with an advanced airway during CPR is A. 8 to 10 breaths/min, B. 12 to 15 breaths/min, C. 20 to 30 breaths/min, D. 6 to 8 breaths/min. Answer A. With continuous compressions, give 1 breath every 6 to 8 seconds, 8-10/min. The first intervention for a choking infant who becomes unresponsive is to A. Perform a blind finger sweep, B. Begin CPR immediately, C. Give back blows, D. Attempt to ventilate first. Answer B. Once unresponsive, CPR begins immediately with chest compressions to relieve obstruction. Which electrolyte imbalance commonly leads to cardiac arrest in dehydrated infants? A. Hypokalemia, B. Hypercalcemia, C. Hyponatremia, D. Hypermagnesemia. Answer A. Hypokalemia disrupts cardiac conduction and increases arrhythmia risk. When using bag mask ventilation, avoid excessive volume to prevent A. Vomiting and aspiration, B. Bradycardia, C. Cyanosis, D. Tachypnea. Answer A. Overventilation increases gastric inflation, leading to regurgitation and aspiration. A heart rate of 50 bpm with signs of poor perfusion after oxygen and compressions should be treated with A. Atropine, B. Epinephrine, C. Fluid bolus, D. Defibrillation. Answer B. Epinephrine supports perfusion in bradycardia unresponsive to ventilation. The preferred fluid for initial resuscitation in pediatric shock is A. 5% dextrose, B. 0.45% saline, C. Normal saline or lactated ringers, D. Albumin. Answer C. Isotonic crystalloids rapidly restore circulating volume. The compression depth for an infant is approximately A. 1 inch, B. 1.5 inches, C. 2 inches, D. 2.5 inches. Answer B. Compressions should be about 1/3 of the chest depth, roughly 1.5 inches in infants. When a pulse is present but the child is not breathing adequately, the rescuer should A. Start compressions, B. Apply AED pads, C. Wait 30 seconds, D. Provide rescue breaths. Answer D. Assisted ventilation is needed if the pulse is present but respirations are inadequate. In PALS, the term disability in the primary assessment refers to A. Spinal stability, B. Neurologic status, C. Blood pressure, D. Oxygenation. Answer B. D stands for disability, assessing mental status using AVPU or Glasgow scales. The preferred energy for synchronized cardioversion of SVT in children is A. 0.5 J/kg, B. 4 J/kg, C. 2 J/kg, D. 1 J/kg. Answer D. Initial synchronized cardioversion dose for SVT is 0.5 to 1 J/kg. If ROSC is achieved, ventilation should maintain PaSiO2 A. Less than 20 mm of mercury, B. 35 to 45 mm of mercury, C. Greater than 60 mm of mercury, D. 25 to 30 mm of mercury. Answer B. Normalizing CO2 prevents cerebral vasoconstriction and maintains perfusion. A common reversible cause of pediatric cardiac arrest is A. Tension pneumothorax, B. Hypocalcemia, C. Hyperthermia, D. Hyperglycemia. Answer A. The H's and T's include tension pneumothorax as a treatable cause of arrest. What is the preferred drug for treating torsades de pointes in children? A. Lidocaine, B. Adenosine, C. Magnesium sulfate, D. Epinephrine. Answer C. Magnesium corrects polymorphic VT due to QT prolongation. The normal pediatric systolic BP lower limit in mmHg can be estimated as A. 70 plus, 2 times age in years, B. 80 plus age, C. 60 plus, 3 times age, D. 90 minus age. Answer A. Formula 70 plus, 2 times age, estimates minimum systolic BP for adequate perfusion. A child in septic shock unresponsive to 60 ml per kilogram fluids should next receive A. Epinephrine infusion, B. Sodium bicarbonate, C. Calcium chloride, D. Furosemide. Answer A. Epinephrine supports contractility and vascular tone when fluids fail. Excessive ventilation during CPR can cause A. Improved perfusion, B. Reduced venous return, C. Faster ROSC, D. Bradycardia. Answer B. High intrathoracic pressure impairs venous return and cardiac output. The first action for bradycardia caused by hypoxia is A. Atropine, B. Oxygen and ventilation, C. Chest compressions, D. Epinephrine. Answer B. Oxygenation corrects the underlying cause of hypoxic bradycardia before drugs. During pediatric arrest, vascular access should be obtained via A. IO route if 4 fails, B. Subcutaneous route, C. Oral route, D. Peripheral route only. Answer A. Intraosseous access is rapid and reliable when 4 is delayed. Signs of poor perfusion in a child include all except A. Cool extremities, B. Weak pulses, C. Pink mucosa, D. Delayed capillary refill. Answer C. Pink mucosa indicates good perfusion, others suggest shock. The target oxygen saturation for post-arrest care is A. 90 to 92%, B. 94 to 99%, C. 85 to 90%, D. 100% continuously. Answer B. Maintain SpO2 between 94 to 99% to prevent hypoxia and hyperoxia. The first step when identifying pulseless electrical activity is to A. Defibrillate immediately, B. Apply synchronized shock, C. Give amiodarone, D. Check for reversible causes. Answer D. PA is treated with CPR and identification of H's and T's causes, not shocks. In pediatric shock, the preferred rate for fluid bolus administration is A. Over 10 minutes, B. Rapidly over 5 to 10 minutes, C. Slowly over 20 minutes, D. Over 30 minutes. Answer B. Rapid 20 ml per kilogram bolus over 5 to 10 minutes restores perfusion quickly. The best method to assess perfusion during CPR is A. Skin color, B. Capillary refill, C. Heart rate alone, D. EtCO2. Answer D. EtCO2 correlates with cardiac output and CPR effectiveness. The recommended chest compression rate for children is A. 80-100/min, B. 100-120/min, C. 130-140/min, D. 90 per minute. Answer B. Maintain compressions between 100-120/min for optimal outcomes. Which sign indicates effective bag mask ventilation? A. Rising heart rate, B. Decreased chest movement, C. No EtCO2 detected, D. Silent chest. Answer A. Rising heart rate and chest movement confirm adequate ventilation. When managing SVT in a stable child, the first step is A. Adenosine 4 push, B. Synchronized cardioversion, C. Vagal maneuvers. D. Epinephrine infusion. Answer: C. Non-invasive vagal maneuvers are attempted first in stable SVT cases. A shockable rhythm in pediatric PALS is A. Asystole, B. VF, C. P, D. Sinus arrest. Answer: B. Only VF and pulseless VT are shockable rhythms in PALS. During post-ROSC care, the most important action is to A. Check blood glucose, B. Give atropine, C. Discontinue oxygen, D. Begin chest compressions again. Answer: A. Hypoglycemia can mimic neurological injury and must be corrected early. In cases of suspected toxin-induced arrest, the antidote should be given A. After 30 minutes, B. As soon as the toxin is known, C. After ROSC only, D. Only if rhythm changes. Answer: B. Prompt antidote administration can reverse cardiac arrest causes. The preferred route for administering epinephrine during resuscitation is A. IM, B. Endotracheal only, C. Subcutaneous, D. 4 or IO. Answer: D. 4/IO administration ensures rapid drug delivery to central circulation. The most important predictor of survival after pediatric cardiac arrest is A. Number of shocks delivered, B. Early effective ventilation and compressions, C. Amount of epinephrine used, D. Duration of arrest. Answer: B. Early high-quality CPR with effective ventilation and compressions remains the strongest predictor of survival.